Everyone, and welcome to your week 3 lecture where we'll talk about improving on definitions and measurement of recidivism. Learning objectives for this week's lesson are that by the end, you'll be able to examine the issues with accurately defining, measuring, and addressing recidivism, critique current methods of data sharing among and between criminal justice and social support agencies, argue for ways in which data sharing horizontally and vertically could be enhanced to improve outcomes for those reentering society, and support the addition of human frailty to the R&R model to increase reductions in recidivism. So this week, we're really going to look at the many ways that recidivism is defined and measured, as well as how data is stored within agencies, and then the challenges that come in when trying to share that data and information across various agencies. We'll also cover the risk, needs, and responsivity model, or the R&R model, and how this drives work with reentrants. Similarly, we will take into account human frailty when looking at ways we can reduce recidivism. So we're going to start out with looking at Chapter 4 of Homeward on human frailty. Human frailty really is just defined as poor mental and physical health that adds insult to poverty. So these are those physical markers that really stigmatize the poor and make incarceration much more likely. Human frailty is persistent, it's sustained, and is rooted in family histories. So the correctional institutions really aren't equipped or created to treat these conditions, and unfortunately what ends up happening is a lot of them get exacerbated while a person is incarcerated. So when we talk about human frailty, we're really talking about being addicted to drugs, having physical health issues, having mental health issues, anything that's going to hinder or make you a little bit more frail or vulnerable to the impact that being poor has, to the impact that poverty has on an individual, that maybe wouldn't impact someone as greatly if they had the money and the resources and the support to address those needs and issues. So again here, what are some of the issues surrounding frailty? As I mentioned, mental health. So we know that of this population in Homeward, 2/3 had a history of mental illness or addiction, that depression and bipolar were frequently reported, and schizophrenia, which the peak onset in males is between the ages of 15 and 24. We also know that there are higher rates of schizophrenia in those who are Afro-Caribbean, and that childhood adversity and adolescent marijuana use can actually be risk factors for the onset of schizophrenia. We also talk about drug and alcohol use and how that impacts frailty. So violent and chaotic childhoods, family violence, mental illness, and sexual abuse are all things that contribute to someone using drugs and using alcohol. Drug use is very typical of someone who's trying to cope with mental illnesses. And of the 54 people who reported a mental health diagnosis, 40 of those had a history of heavy drug or alcohol use, which shows you that the majority of them were trying to self-medicate. And then 25% of people had PTSD, anxiety, or both of those who were using drugs to cope with their mental illnesses. And then chronic pain and illness was also really highly reported among these Homeward populations, which you'll read about more as you continue on in the book. But 1/3 of them experienced serious back pain, arthritis, or other disabilities. They had hepatitis C, heart conditions, and 38 of the 42 cases of back pain, arthritis, or physical disability were found among those who had addiction or mental health problems. So sometimes it's the question of, what came first, the chicken or the egg? It's what caused what is still causing what, and what came first. They all sort of come together. Was it just the perfect storm that created the mental health condition in someone? Was it the mental health issue brought on by drugs or alcohol? Or did drugs or alcohol, were they used to cope with a mental health issue? Were drugs and alcohol used to cope with chronic pain or illness? Or did someone give themselves a chronic illness through years of alcohol use? Really, to address one, you have to address all. So how then is rehabilitation impacted by all of these human frailty issues? Well, an individual's motivation to change is going to be impacted by addiction and by mental illness. So it may not be that, I hate saying the term that an individual's motivation to change is impacted by these things, because maybe the person truly does want to be motivated, or they are motivated. However, coupling that with the use of drugs, coupling that with having a mental illness or a mental disease, it's very hard for a person to function normally, to think critically, to think rationally. So it impacts their motivation to change because they have these other factors going on in their minds. It also assumes a level of willpower that's typically unrealistic due to a lack of physical or mental capacity to effectively intervene in their own lives, right? So just what I was saying, it's very difficult when you're also struggling with these diseases and disorders to have the willpower to overcome them. And if you've ever had someone in your family or known someone who either struggles with addiction or struggles with mental health issues, you can see how hard it is firsthand for these individuals to get motivated to want to change, be motivated to even get up and get out of bed in the morning to go participate in a program. And then we have this need for continuity between prisons and communities, right? So if someone has these human frailty issues, if they have drug addiction, mental health issues that were being addressed within the prison, we have to make sure we have continuity of care when they return to the community, so that these issues aren't just left untreated when the person is in probably one of their most critical states. We learned before, how just stressful it is re-entering society, how stressful that experience is. So to have that and then have to deal with these issues on top of it doesn't really lead one to make the right choices or make appropriate choices. In our next article, we talk about looking at the text Beyond Recidivism toward accurate, meaningful, and comprehensive data collection on the progress of individuals re-entering society. So the only reason that we even know what we know is because we collect data, we collect information. And I know that data collection is not, and data in general isn't everyone's cup of tea. It's my favorite, to be honest, because it just tells you so much about individuals. It's the only reason we have this information on reentrants. So it's important that we understand data collection and why it's important with these populations, right? So we know that the rate of imprisonment tripled from 1980 to 2008, though since then the rate of imprisonment has been declining. The incarceration rate in the US is a rate 5 times the other countries when compared to those that have similar crime rates as us. And recidivism definitions vary widely. So when you're talking about recidivism, we'll talk on the next slide about the different ways it can be defined, and it makes it difficult then to compare data across different agencies or organizations because they're not talking apples to apples. They may be talking apples to oranges. And then relapse into criminal behavior alone really is a poor measurement of someone's success in reentry, because all you're measuring is one singular event, one singular poor choice that they made in their life, not looking at all of the other things, all the other rehabilitative programs they might have engaged in, or the relationships they may have rebuilt. What it also doesn't tell you is how much access they had to rehabilitative programs, to reentry programs, to resources, so that they could desist from criminal offending. It just tells you whether or not they did. So how do we define recidivism? Many ways. Recidivism, when you look at it definitionally, typically is a rearrest for a new crime or a violation of supervision. So 2 different things looking at there. Reconviction is an arrest followed by a court conviction. So a conviction, they have been reconvicted of a new crime. Reincarceration is having a conviction or a revocation of parole that leads to someone serving time in jail or a prison. So reincarceration, they are spending time again in a jail or a prison. And then technical violations, which is any violation of the rules of supervision, which can be a positive drug screen, missing a meeting. There's such, if you're a gang member, having gang paraphernalia, such as bandanas that are the color of your gang. It can be if you have firearms offenses, having bullets, having any type of weapon in your home. You're not supposed to have any weapons when you're on supervision. So any of these can be grounds for a technical violation, which can lead to, if you look back, counting that as recidivism. It can also lead to reincarceration. So again, how are we defining the term recidivism? You have to understand the specific way that whatever the article of research is that you're reading is defining it. So what does our current recidivism research look like? Well, we need to also know, and in addition to how we're defining recidivism, what look back period are we looking at? How much of a time frame are we looking at? 1 year after they've been released? Are we looking at 2? And this is going to vary by the agency, organization, both at a state and federal level, which means, again, it's very hard to compare data if you're not talking about the exact same thing. There's also disparities in enforcement that can lead to racial disparities throughout the whole criminal justice system. So disparities in how maybe rules or violations of the rules and conditions of probation are enforced. Maybe one officer really enforces those rules. You miss one meeting, we're arresting you. Maybe another officer gives you a chance or two to make contact. I'm going to tell you in PA, it is very rare that we're going to violate someone on probation or parole for just simply one violation. And in fact, Act 44 legislation actually tells us that what we have to do for probation for a violation is we have to have 3 separate violations to be able to bring someone back in. The length of post-release supervision. So how long is somebody on supervision after they're being released from prison affects the recidivism measurement, because there's now the potential for violations, which can increase the chance of reincarceration because someone's watching their moves, as opposed to someone who was released outright, who served all of their time in prison and now isn't on supervision, so they don't have to worry about all of those extra rules. They just have to not break the law. You also have sentencing policy, parole procedures, and departmental differences in how records are kept. So this makes it hard again to compare data, and I'm going to keep driving that point home, because maybe one department keeps records on violations, but another department doesn't have the same amount of funding and can't keep records historically of how many individuals were violated or what the violations were for. And again, here we're measuring only re-engagement with the system, which fails to capture other successes and failures they have. So we need data on criminogenic risks and needs and services that are provided to these people to see if improvement was made. But really, this is so complex because you could use maybe case plans to figure out and track if they've reached their goals or not. You're looking at so many different areas like education, employment, training, whether somebody's receiving disability benefits, mental health, childcare, transportation. There's so many. So, what do you measure? What is important? What impacts recidivism? What doesn't? How are you measuring achieving goals? Is everyone setting goals with individuals to be able to measure those factors? And then there's also political factors and climate and budgetary restrictions that can create barriers for departments. So if a department doesn't put data collection as a priority, then that's not something that they may be able to share with other agencies. At the end of the day, we still need to be able to show that we are making progress, or to show if what we're doing is working. And how do we do that if we don't have data? So what is the power of data sharing and integration? Well, when you have data integration both vertically and horizontally, and you have better communication, you can improve service delivery, you can improve the effectiveness and efficiency of those services, and you save money. So when we talk about integration vertically and horizontally, we're talking about integrating, say, at the state level, but also the federal level. We're looking at probation departments and social justice organizations. We're looking at treatment providers at all sort of levels and ways that programs and services are connected to one another or are serving the same populations, then it's really important that we're sharing data, communicating well, and making sure that we're not maybe double serving an individual, that we're serving all of their needs within the quickest and shortest amount of time, effort, and money that it would take to do that. So for example, if you have one agency in your community that can give someone employment and educational services, and maybe they also have drug and alcohol services there, let's put them in that place instead of sending them to the local community college for education, sending them to a secondary job readiness program, and then also trying to set them up with a different treatment provider, right? If they can get all of those things in one place, all the better, saving money. Also, an individual can be on supervision in multiple jurisdictions at the same time. So are we double counting data? How do you compare that? And then somebody can also be doing state time, but is being supervised by county probation. So again, where does that person fall when you're counting or collecting data? How are you defining your terms? As someone who's on supervision, is it someone who's on supervision no matter what type of time they served, no matter what their offense was? You have to be very specific when you're collecting and sharing data in the criminal justice field. And then better communication between even your treatment providers, your jails, your homeless shelters, and all your programs, so that we don't keep doing something if it's not working. And then we can also improve comparisons when we're collaborating better with these agencies. So what are some obstacles that might stand in our way? Well, confidentiality and data security. So are we able to share the information with other treatment providers? So in the juvenile world in Pennsylvania, a lot of treatment providers are provided at cost to the probation department for the juveniles. So the juveniles can be put on family counseling, individual counseling, aggression replacement therapy, drug and alcohol treatments, all of this through the probation department, which means because they're paying for it, they have access to all of their treatment records and all of the information that they would need. However, in the adult system, that's not the case. Individuals are always required to either get through private insurance or state insurance their treatment and their services. So what happens here is confidentiality issues. So if the treatment provider does not have a signed release form from that offender, then they can't share that information with the probation department. Similarly, if the probation department doesn't have one signed, they can't share information with treatment providers. And this really just makes for a more complicated process. Most of the time, individuals have no problem sharing and signing these release forms so information can be shared because they want their parole or probation officer to know they're doing a good job, to know they're participating in programs. But maybe there's somebody who just doesn't want that information shared with their probation officer. So how do they get that how do they know if they're, participating, and how do they know if they're reaching their goals and being successful? You also have incompatibility of hardware or software technologies. So really just having the means of data, being able to collect that data and store that data in an efficient way. Lack of budgets and staffing to do that work, and maybe just a lack of motivation. Maybe it's not a priority for that department to collect data and information because they only have enough resources to really get the job done, to not actually collect all of this information. And our last article we'll look at is community capacity building and implementation advances to address that R&R framework. So with all of these issues that we have, sharing and collecting data, how do we implement sort of human frailty into that R&R framework? And how does it help us to do that? So recidivism reduction in context really just means the program or practice will reduce the likelihood that a person will have further contact with the system. So we talk about what works are just your evidence-based practices. So those that are supported by the research to reduce the likelihood of reoffending. So these are done in typically through things like cognitive behavioral therapies, which are in a community setting. They typically tend to target high-risk individuals and include either an anger management or a cognitive restructuring component, which cognitive restructuring is simply saying, here's what happened, here's what I was thinking, what I was feeling, the thoughts I had, and here's the action I took. And restructuring their thoughts to say, maybe I was feeling really angry and pissed off, But instead of telling myself, wow, I really want to punch this guy in the face, instead I'm going to tell myself, it's not worth it. I don't want to be rearrested. I don't want to be violated for my probation. I want to complete this successfully. I just don't want to be in any more trouble, which then leads to improved behaviors because you're telling yourself something different. You're not getting yourself stuck in that negative self-talk, essentially. You're having positive self-talk now. They can consist of supplemental individual sessions at times if it was typically a group setting. They also have to be held in sufficient duration. So dosage and duration is something that's talked about in the criminal justice field. Dosage is how many hours is the individual receiving. Duration is how long, over the course of how much time. So ART, for example, when we did that with juveniles, I want to say it was 10 weeks and 2 hours each week for dosage and duration for it to be for it to be effective with individuals. And they have to be well implemented. So you have to make sure that the program is implemented to fidelity, that everyone is doing the same thing to receive the same outcome. Then you have your R&R model, which is your risk needs responsivity, which again targets high-risk individuals, focuses on criminogenic needs, but also factors in responsivity. So when you're factoring in responsivity, you're factoring in all of those components that really speak to who the individual is. So your criminogenic needs are your antisocial thoughts, behaviors, peers, families, looking at substance abuse, education, employment. Responsivity is looking at how does the person learn? What is their developmental age? Can they read and write? Are there cultural factors that we have to take into account? Are there mental health factors that we need to take into account? So these are all things that can affect how responsive one will be to whatever treatment or therapy or programs they're being placed into. So how do we modify that R&R framework to include human frailty? Well, the R&R framework as it stands now doesn't include social determinants of health, socioeconomic status, or behavioral health factors. So housing, social support, food insecurity, and mental health all play into recidivism. So there's an argument here to have primary needs versus secondary needs and looking at both of them and addressing both of those. So you want to address the top 4 criminogenic needs, which is your primary needs. And then your secondary needs are when you're focusing on things like the substance abuse, employment, education, leisure. You're focusing on all those other issues that are sort of going to impact one another. And I mean, we always push focusing on primary needs first, but there's a really good argument in this study to have secondary needs addressed as well. And making sure that you have sufficient services for protective factors, which can lead you to having a reduced need for justice-related services, right? So if we have appropriate services and sufficient services already in place, already in the communities to help with those protective factors, those factors that really insulate somebody from having contact with the criminal justice system, then there will be no need down the line for those justice-related services. So looking at a case study in St. Louis, Missouri, looking at general population they looked at general populations versus justice-involved populations, and they compared the capacity versus need for services in social, substance abuse, and life areas between these two. And what they found was the general population really lacked interpersonal skills and life skills, but they have substance use disorders, they have decision-making, they have self-management, and other types of programming. Whereas the justice involved were lacking substance use disorders, self-management, and interpersonal skills. So we see that a lot of these populations have similar needs. So when we talk about criminogenic needs, it really seems like we're simply talking about characteristics of lower socioeconomic status and minorities. They all suffer from the same issues. They have a lot of the same needs. So a lot of them were similar for the general and the justice-involved populations, which goes back to that point that if we would start addressing those secondary needs, or if we would have sufficient programs in place for the general population, then we wouldn't need justice-involved or justice-related services later on because they already would have been addressed. So again, factoring in sort of Maslow's hierarchy of needs is really important. The text will talk about how important it is that we have our psychological needs met, that you can't have anything if you don't have that. If you don't have food, clothing, shelter, you can't have anything else on top of it. Then you need to feel safe. You need to have appropriate health services, mental health, physical health. And then comes love and belonging. Do you have those friendships? Do you have family and social supports that you can feel a sense of connection to? And then from that, you can build on that to have self-esteem, to have sort of that feeling of respect, and then self-actualization, where you desire to become the most that you can possibly be. And you can only do that when all of these other needs are being met. And we find that a lot of these psychological and safety needs aren't being met through the reentry population. So how do we expect them to form, new redemptive identities? How do we expect them to become pro-social individuals and have self-esteem when they don't even know what they're eating for dinner? They don't know where they're sleeping that night. So here's a few suggestions that your researcher gives for improving the risk needs responsivity framework. One is that we revise the estimate of recidivism reductions. So if programs and services don't attend to food security and housing instability issues that are going to impact more long-term recidivism reductions, then we need to take a look at really how much can they reduce recidivism. We also need to emphasize food, nutrition, and housing security within those programs. And then develop a prototype program and services to incorporate those critical services that somebody needs, and then sort of studying that and seeing if it really does lead to greater increased recidivism reductions. In sum, recidivism is defined in a number of ways, which makes it difficult to compare data across and even within agencies at times. Lack of communication, software incompatibility, political factors and climate, and differences in those recidivism definitions are obstacles for current data sharing. Improved service delivery, effectiveness, efficiency, and cost savings would result from better data sharing, both vertically and horizontally. And we need to make sure that Maslow's hierarchy of needs is being considered within that R&R model, as food and housing security are really critical to long-term recidivism reductions. So that is your lecture for this week, and I really hope that everyone has a wonderful week.